Thank you. So if I'm sitting in your seats, the way to remember this anticholinergic is this right here. You don't have to know every single thing that's there, but you do need to know the fact that how the patients will present. Okay? They're not going to be diaphoretic. They're not going to be pale, colon, and wet. The idea that they're going to be up. So with that, what would you want to do about this right here?
Slow it down.
Again, that's what our inclination says, is that we want to slow it down. But these patients, this group right here probably will not be SVT. This group will be 130, 140 along the way. You're scratching your head going, why are they in this tachycardic rate? Well, looking at their skin, looking at their symptoms, finding out what their history is along the way will give you a clue in terms of what's going on. Okay?
IV, O2, monitors, serial quality.
Supportive type stuff. Absolutely. Can they end up having a STEMI with this? Yeah, this could drive it, especially if they have a coronary disease process.
Is this just something to kind of keep in the back of our mind as things that could be, or because I've transported somebody with the same blinded bat out of the hair, right?
Yeah, so it's like I just mentioned a second ago, the idea that you're not gonna, you may not necessarily save any lives with this, but the idea that you're gonna do supportive care along the way and realize and recognize what it is. Make sense?
He was excited delirium
Yeah.
from meningitis.
Right, and so you can have a population, a complete population that's off the grid. And so this typically is not quite that, but they're certainly agitated along the way. So you can have somebody with ED and just not quite from this. Make sense?
Yeah.
All right, another one that you need to know, cholinergic. The last one was anticholinergic, this is cholinergic. Okay? Look at the opposite in terms of what's going on as far as signs and symptoms. What's the difference?
They're no longer dry.
That's a true statement. but check this out. Don't lose this. The idea that we're talking about two different agents, two different toxins, right? One is anticholinergic, the other one is cholinergic. And it's certainly not dry here. Okay? So fluids are coming out of every orifice in their body, right? They're drooling all over themselves. Diarrhea. They're peeing all over themselves. So it goes on and on in terms of moving fluid. The skin is going to be what? Diaphoretic, right? The idea of looking at the possibility of a cholinergic agent or organophosphate poisoning. When might you get into this? We talked about it a couple minutes ago. So pesticides can be all by itself, right? So in a farming type community, dust problems again. But the idea that you should be asking the question in terms of what do they get into, either intentionally or unintentionally along the way, when they present like this. Okay? So it'd be good, just one way of remembering this. Dumbbells with two different S's. So diarrhea, urination. What is meiosis?
That's cellular division. That's mitosis.
Yep. So if the opposite was dilated pupils, this is pinpoint pupils. What are you thinking of? Let me get some Narcan to say this. Are you having a reaction? Nope. Bradycardia, emesis, lacrimation. What's that?
Right.
Yeah, or tears, right? They're going to lose it through tears, okay? Lethargy, salivation, and seizure. Classic setup. Has anybody seen this before? Just one time. That's all it was. Just one time. And they were truly into our organophosphate poison, which was kind of interesting all by itself. So when we get at the very tail end of you being here, we're going to talk about terrorism. We're going to talk about certain agents that are out there. There's agents out there as a possibility in terms of organophosphate poison. There's one more thing from a terrorist standpoint, which means that we're talking about a whole problem of the possibility of what we that's a completely different thing. because of this right here, they'd be hypertensive. Now, what would they show up in terms of a monitor? Yeah, it might be a sinus break, might be blocks along the way. Everything is through. So we talked about CO, and again, we're going to just touch on it here, and then we'll come back and talk about it in a week or two as far as pulmonary. Leading cause of poisoning in industrialized countries: odorless, tasteless gas, often byproduct, extremely stable molecule. So the idea that it's going to take over a red blood cell and maintain it for a long, long period of time. Half-life of carbon monoxide is somewhere around 6 to 7 hours. So it's there for a long, long period of time. Has anybody had the unfortunate thing of carbon monoxide? Yeah?
Deer Park over the summer, lady just got divorced from her husband.
Yep.
Had a bunch of mental issues.
Yep.
Locked herself in her car.
Mm-hmm.
And she actually had taken a handful of pills too, but she turned the car on and running for 10 minutes. Her husband happened to come over because her ex-husband yarded her out of there, and the first thing we did is just put her on 15 liters for 60 once he won't show up. But yeah, she was just completely out of it. She started to come around by the time we looked at her.
Yeah. So let me tell you about my war stories, and I'll tell you about a personal story, me, and then I'll tell you about a patient that took care of that I thought was kind of remarkable. Way back in the day. So by the way, the Olympics is starting this week, and the area to where the Olympics is taking place is a base that I was in. Very first assignment in the Air Force. I paid for my wife to come over. It was not a sponsor type thing, but I paid for her to come over. And we lived in a little one-bedroom type apartment. Interesting thing in terms of the way the Koreans heated their places. Back in that day, hopefully they've gotten better at it, but back in that day, they were using pop cans that they would solder together, run underneath the floor. They had a charcoal, and the charcoal was about like this, and they would put it in the floor. They'd burn it along these pop cans in terms of getting rid of it, off-gassing it at that point. But the idea of the way that it heated was it heat the floors, and so as a result of that, the heat came up to the floors, and you were supposed to be warm. So it worked kind of well. It worked okay, but every single year there was military guys that were checking up with girls downtown, and they would be overcome with carbon monoxide. So for us, my wife got up one night about 2 o'clock in the morning or so, and used the bathroom, and she was lightheaded. She comes back and she wakes me up. And as soon as I sat up, there was a headache that came on, just like that, and dizziness, just like that. And so we got up, we got out of the house, had a pretty good clue what was going on, got up and got out of the house, and we had to sit in the courtyard because there was, you couldn't be out on the streets until about 6 o'clock in the morning. And so there was a curfew that was on, and so we sat in this courtyard for the next 4 hours or so, 3 or 4 hours or so, until you can get outside on the street. And I will tell you that headache persisted for about 7 hours. We didn't do anything in terms of oxygen along the way, but a very long-term type of effect that was created. So I've had personal experience with it. I was fortunate enough not to die in that thing. Probably another 2 hours or so, and life would have been different. So the flip side is that over in Cooney several years ago, I had a patient similar to what you're talking about. This was a young guy, 19, 20 years of age, who locked himself in the garage and started the motor and carbon monoxide and thing. For whatever reason, that particular day, they would come over to check on him and found him in the vehicle, and we got a call for that. So you all know what a RAD-57 is. Have you heard about a RAD-57? Know anything about it yet? I know you guys are hearing it. So RAD-57, for those of you that don't know it or haven't seen it before, essentially it looks like a pulse oximeter, but it measures CO, measures carbon monoxide and the amount. So as you get the pulmonary side next week or the week after, you're going to hear a little bit more about this. But the idea that you put this on the finger and you can measure carbon monoxide. So you and I, as we're living and breathing right here, right now, we've got small amounts in the air. So it's probably about 2%, give or take, that you and I are living with right now. If you happen to be a smoker, you probably live with about 5, 6, 7% or so on a normal day. So that's kind of like normal. As you get higher than that, you get higher than 10% or so, carbon monoxide is a really huge issue in terms of red blood cells versus carbon monoxide. And so anything above 10% becomes a problem. When you get to 25%, then usually hyperbaric medicine is it's controversial. Hyperbaric medicine is a possibility for treating these patients. And so the idea in terms of this patient, we flipped this graph 7 on him, and he was showing 56% initially. Intubated him, and in a short period of time, transported him to Fuji. So probably a 10-minute transport went from 56% down to about 22%. So you can get these patients turned around in terms of carbon monoxide. It doesn't mean they don't have the carbon monoxide on the cell. It just means that from a ventilatory standpoint, you can get them turned around really quickly just by ventilation all by itself. And so lesson to self is think about the airway, what you're going to do about the airway for these patients outside of taking care of yourself. Does that make sense? Okay.
Does the body compensate for that over time? But like,
so if they're healthy enough to do that, the answer is yes. But if you got somebody that's critically like this guy, the outcome was he went to hyperbaric medicine over here at Deaconess at the time, and so for him the compensation wasn't that great.
Yeah.
For somebody that can get up and walk around and everything else like that, compensation is really easy.
Like you get the people that chain smoke all day.
Mm-hmm. Absolutely. So if you happen to be right, if you happen to be a COPD or asthmatic or the likes of, then it's going to be that much greater as far as that exacerbation. So you can hear some more about this. Why would you want to get Serio 12 leads with carbon monoxide? How's it going to show initially when carbon monoxide is on board? Depressed ST would be one thing. I'm sorry.
I just said ischemia.
Yeah, so ischemia. What else are you going to see? Yeah, probably tacky. Yeah. How about PVCs? One more reason for the possibility of ectopy along the way would be this right here. Cyanide. Anybody outside of firefighters and outside of coming out from interior to exterior? Anybody had anything with this? So it's out there as a possibility, and the good news is that most of these patients that are suicidal that end up with cyanide in the vehicle itself have left a note. Just kind of interesting about that. So the idea of them being very generous to you, telling you that there's cyanide within this vehicle, well, the day's coming. I will tell you, it's here, where you're going to find somebody that's suicidal, has taken their life by cyanide, and now that you know about that. So you're exposed to cyanide as a possibility. You won't know it. You won't know it in terms of signs and symptoms until it gets worse along the way, or many are affected by it. The way that it works is aerobic metabolism. They go into anaerobic metabolism. We talked about this, so I'm not going to hang out here. The effects of CO, you need to think about cyanide to go along with it. We talked about hydroxyproline, and we talked about amyl nitrate. You should know that when we're talking about this kit is still out there. You should know that the kit includes not only amyl nitrate, sodium nitrate, but also thiazolate solution. Those are the 3 portions of the cyanide kit that make this up.
Is that pretty tough on your kidneys to remove that?
Yep, absolutely. So amyl nitrate is inhaled, sodium nitrate and sodium thiazolate are given with IV push. They will bind with a cyanide and ends up removing it from the kidney. So in this case, the kidneys will be take the workhorse of this, but again, the liver is affected by that.
Let's see where we're at.
Go ahead and take 5 minutes. Come on back.
Your just found it and made it essentially B12, and so it's just kicking out extra B vitamin, right? So why would that be damaging to kidneys?
Just because the amount that's private. So ADH would be went into play here. So the liver would, or the kidneys would have to work harder and harder to excrete.
Gotcha.
Hey, well, where is she? Good. Yeah, good. You did that, like signs like that. Just a little like $5 bucket. Was good to go.
Fireworks. Oh, great. Yeah. Well, you got a big all the way over. You're dead. Shot. Yeah, you're trying to go. I understand.
They do.
Oh, yeah. That is.
Yeah. Well, we had a CO thing. We had a.
So there's like 10 of these things on our book. Do we just need to worry about the cholinergics and anticholinergics? You know, that's we'll talk about this.
The cop went in and he said, oh, yeah, he's wrong way. We walked in there and it's just a little weird. The way he died was so weird.
Why would you do that?
Like, how the company shape you walk around and you say, the window was cracked. And I looked at him, it looked like he was like face down. He'll go over here, he'll go over. You see a hose coming from the window. So I look out the window, it's attached to the floor that he has. And I was like, luckily this door was out of gas. Yeah, because if not, everybody was walking in there and stepped out of there. Really quick. I was like, okay. He got very little, just a little phone. It was just a really rare setup. It was the same thing. You know, this bossy, you know,
Oh, those are great.
Okay, you would have never known that. Like, you're trying to explain it's like what happens to see his face and see what was going on. It's just like, oh, like those about that.
I'm sure you've seen the video of the firefighters camera.
Last
They went all like that.
I've seen it on YouTube, never seen one.
Yeah, I feel like, well, for us, like a scene culture, you walk out of the
Yeah. I never
yeah, that, that's
They used to help several times. They were really well. Now, I think it's already on the
really quickly.
You all right?
Well, she just calls you guys because.
Same thing, probably.
Okay, so it's not necessarily.
I had to read about
We're actually transporting.
Before, yes, yeah. Yeah.
She's
The one that they talk
It takes like 2 batteries.
Yeah, it's so cool.
Looks like it's toast.
It's like I want one of those.
All right, let's go. So we have been talking about hydroxycobalamin, and that's probably more common than what you're gonna see out there. The idea that should be given based on the presentation, based on the possibility more than anything else. You know, include the patient population as well. Side effects can include red skin, elevated blood pressure. Talk about that. So we're going to touch on it here, Dr. Edmondson. We'll talk about it some more next week, but the idea in terms of cardiac medication, very, very common in terms of the elderly population for the possibility of overdosing based on a number of different factors. And we'll talk about geriatrics in several weeks. But when we're talking about an antiarrhythmic, we're talking about the possibility of amiodarone. So what's the good news and bad news about amiodarone? Because there's both. Good news is it's fairly effective in terms of what you're doing, right? So the likes of BFAC, the likes of BFib are fairly effective along the way. What's the downside? We're talking about days and months, right? So check this out. What do you know in terms of what we're using amiodarone for? What rhythms? BFAC, BFib. Anything else? Yeah. So rapid AFib as well. And a whole host of other rhythms along the way that we were talking about. So while what we study here is those primary rhythms, I'm here to tell you, your patient population will be on this AFib very, very often, very frequently. As a result of that, the possibility of overdosing on this is real. So how would it show up in terms of cardiac rhythm? Fast or slow? Think about what it does. How would it show up? Overdose. Slow. Big down wide. Blocks would be very, very common. Right? So in your hip pocket, the idea as far as what you're doing should be this consideration differential. So the beta blockers, we talked about this in terms of treating at home. Is it good? Is it good? Don't think you should share with everybody.
No for breakfast, huh?
So are we.
Right. So we're going to talk about beta blockers in terms of overdose. Again, fairly common possibility with overdose. Okay. Calcium channel blockers. The thiazide rapamycin, those very, very often. The thiazide has got a fairly long half-life as well. And yet you're going to have your patients, think about all your patients who run into with AFib or aflutter history, especially AFib. The idea that this is always in your hip pocket for the possibility of overdoses. Digitalis, old type drug that's been out there forever and ever. But Digitalis overdose is ugly, very, very ugly, to the point that we're talking about huge blocks, to the point that we're talking about maybe the ventricular rhythm. Digitalis, it's got a life all to itself. And then finally, the prills, the ACE inhibitors would be another possibility. So in general, how they're going to show? Well, certainly nausea and vomiting is a possibility in all cases, right? But headache, dizziness, confusion, profound hypotension, in all the cases we're talking about, profound bradycardia, that's not going to be responsive to what? Is atropine going to work here? Nope. In all cases, atropine is not going to have an effect on anything we're talking about. So this is one more reason. If you don't know the history, you don't know why you're there, or why there's bradycardia along the way, and it doesn't respond to atropine, it doesn't respond to pacing along the way, you should be thinking, I wonder what they're taking that's creating all this, right? So toxidrome can come into your A's and P's. Blocks, bronchospasms, and pulmonary edema, depending on what agent we're talking about. Beta 1 versus beta 2. All right, so you need to know this. You should know this already. This should be part of your thing. But the idea that when we have severe bradycardia that's not responding to atropine, we should consider the possibility of calcium channel blocker overdoses. 2 to 4 milligrams of calcium chloride or 10 to 20 mils of calcium gluconate. With the beta blocker overdoses, we're talking about glucagon 3 to 10 milligrams IV push. How many of you are carrying more than 1 amp of glucagon, if you're carrying glucagon at all? Good, too. Okay. So unless you're getting access from somebody else, as far as another kid or something like that, chances are you're only going to have 1 milligram. Should you give that 1 milligram? Oh yeah, you start the process, but are you going to expect huge results out of that 1 milligram? Not so much. Does that make sense? And so the treatment in both cases is that you're going to start it. Talked about this last week, and I talked about it again today. The idea that you can get electrical capture here, but won't be able to get mechanical capture based on some sort of an overdose should give you one more clue that you're dealing with a toxidrome. Yes? The idea that it's not responding as it normally would should be consideration for something else. Yeah.
Is that something we may see changing our protocols then, carrying more glucagon if that's?
I don't think so. It's been around forever, and I mean we've kind of talked about it in terms of trying to push it out there, but I don't think they're seeing it that much. So.
Does it have a short shelf life or pretty?
Glucagon? Yeah, fairly long. In general, what I see is probably a year or something like that. But it's pricey. Yeah, it's pricey. That's probably the other reason we're not carrying more. So we talk about caustic substances. We're talking about acids or alkalis. And so remember a long time ago we did acid-base balance, and we talked about that sharp, that 0 to 14 kind of thing. So we've got a base, we've got an alkali, and that's kind of what this is here. The difference is that depending on what it is what it will create in terms of toxidrome. And so that's kind of this. Strong caustics will produce severe burns at the site of contact. If ingestion, tissue destruction at the lips. So remember that anything that's happening at the lips is going to go down. So in many cases, we're talking about kids. And so destruction at lips, mouth, esophagus, areas of GI tract. What's an example of a strong caustic?
Drano.
Exactly. So again, a child gets into something underneath the cupboard would be a pretty good example of how that might work.
That's like my Kool-Aid.
Yeah. So strong acids, a pH less than 2. Again, remember that you and I, 7 is neutral. You and I are living just a wee bit above that. So strong acids is much less than that. We're talking about battery acid. We're talking about some drain cleaners. Can be on either side. Can be an acid or a base. So with it comes immediate severe pain. Produces eschar at the burn site. So it's got this burn type thing to it. Strong alkalis, pH greater than 12. Drano, liquid plumber, is a good example of that. Causes necrosis around the area. And so that's one of the huge things about it, as far as what it does with the tissue. So think about the fact that with necrosis, all that skin is going to be dead. They have to cut away based on that. Passes quickly through the esophagus and more likely to cause damage to the stomach. So 2 to 3 days worth of exposure, all the protective mucosal tissue is gone. Wonderful, wonderful setting for the rest of the life, right?
What does it mean by central chest structures?
I'm sorry, one more time.
Central chest structures?
We're talking about the lungs. We're talking about the lining around the lungs.
If somebody ingests one of those stronger alkaloids, would their stomach acid help protect them?
To a certain degree, but there's not enough stomach acid in the world that's going to be there that's going to neutralize that. But to a certain degree, depending on what they've taken in the past as far as food. Causative substances, signs and symptoms would include facial burns, pain in the lips, drooling, trouble swallowing, hoarseness. The hoarseness in terms of whatever product that has gone down their airway.
Is this a good time to talk about sidebar challenge?
All right, so let's camp here. Tricyclic antidepressants, TCAs, okay? They're called tri because it's made of 3 different compounds going away. They are antidepressants. They've gone away in a large degree back in the 1950s and 60s to where they were starting to treat depression with medications along the way. This was like the miracle drug. Everybody was on tricyclic antidepressants. Not very young at their age, but the idea that through the 50s and the 60s and even into the 70s, this was the drug of choice for treating depression. So Elavil is a very, very common name to tricyclic antidepressants. There's a number of other ones that we'll talk about here in just a second. They've got what Matt was talking. I think Matt, you were asking about the narrow therapeutic window. Somebody was asking about that. The idea that it's easy to underdose. The idea that it's very, very easy to overdose. The idea that your patient is determined to overdose on this, it's one of those nasty drugs that are going to be covered. Okay? They may be responsible for more deaths due to intentional overdose than any other medication. And yet we have it in the antidepressant population. By itself, right? Amitriptyline, dioxetine are generic names to it. How will they show up? Where have you seen this toxicology before? Hot as the hair, mad as a hatter, right? That phenomenon would be this right here. Okay? Is it going to get worse over a period of time with TCA overdose? Has anybody have treated these patients or know their medics that have treated these patients? Josh, have you seen them in the hospital? Yeah.
Yeah, we had a patient. So the doc wanted to give her what's called sodium hydroxide.
Yep. Spot on. That doctor was spot on. Okay. And we'll talk about why here in just a second. Are you going to cure these patients in the pre-hospital setting? No. But here's what's going to happen. TCA overdoses, one of the ways you can identify it on a cardiac rhythm is wide QRS complex. Wide, slow QRS complex. So all this time we've been telling you about why you're supposed to think about hyper-K. It's still true, it's still spot on. But included to your arsenal now, the possibility of TCA overdoses being another reason as to why they're wide and slow. Especially with the population where you find pill bottles on scene, they're unconscious, they're hot to the touch for that possibility.
Bicarbonate field, calcium, anything like that?
So bicarbonate field, no calcium. Okay. We'll talk some more about that in just a second. Okay. So we were talking earlier, I was telling you earlier that you hook up to a cardiac monitor, if you want to see a narrowing QRS complex, this is one of the ways to see that. It will narrow right before your eyes. Does it solve anything or everything? No. The answer is no. But one of the ways you can start to appreciate the fact that these patients are getting sicker and sicker is the fact that ultra-level consciousness temperature that gets worse, hypotension would be another thing because of the Y complex bradycardia, right? So the idea in terms of based on signs and symptoms, based on medications you're taking along the way, will tell you if these patients are getting worse. So check this out. We somehow think that, the next time you're going to see a TCA overdose, you're going to pull out your bicarb and here we go. And the answer to that is not always. Usually, most protocols will say, most feeling is that you're not giving bicarb until you start seeing a widened QRS. But once you start seeing that, you aggressively go with bicarb along the way in terms of trying to turn that from anaerobic metabolism back into aerobic metabolism. Amitriptyline and Eladil are one and the same. So you're gonna see that name as being very, very common along the way, right? Late overdose. So the idea that this is early, this is how they present early on, but as this gets worse over a period of time, this is where it's going to. So confusion, hallucinations, hypothermia, respiratory depression, seizures, tachycardia, hypotension. So the tachycardia is still, and I told you bradycardia, right? But the idea in terms of where this is going to, this is quickly going from tachycardia into a bradycardia type thing. And the bradycardia is not going to respond to atropine typically well. One more way that what you expect to happen is not happening with this population. And the cardiac arrhythmias is everything that you expect to talk about. So know that if you have somebody with amitriptyline type overdose, that it's probably going to get worse right before your eyes. So to that, in your book, I think it's still in your book, TCA overdoses, we're going to talk about identifying it for what it is. Poison Control Center is going to help you out in terms of that. The idea in terms of activated charcoal would be a consideration if you need your patient to do that. Certainly a monitor. I would not wait down here to put your monitor on. I put the monitor on right there, right up front. And no, public pads as well as a possibility. Obtain venous access. Are they hypotensive? If they are, then consider fluid boluses. If they're not, then certainly a 12 lead. And again, I would not wait way down here with this algorithm. I'd put that 12 lead like way up here. If their QRS is greater than 0.10, then we're considering bicarb at that point. So it doesn't have to be all that wide for the consideration of bicarb. And then finally, rapid transport and monitoring these patients.
1 ml equivalent?
Yes, still the same dose. Okay. So again, here you see amitriptyline and Eladil as being one of the same. What's another common one? Norepinephrine right here. How do you say it? Desipramine is another common one. Norepinephrine, Pamelor is another common one that's out there. MAO inhibitors. What's this about? Any idea? This is another group of antidepressants. Anytime you're saying MAO inhibitor, we're talking about antidepressants. It works on what in the brain?
Serotonin.
Yeah, serotonin and dopamine within the brain. Well, dopamine that you and I get, but dopamine with our cells in the brain. So MAO inhibitors used to treat depression and obsessive compulsive disorders. Again, narrow therapeutic index. So overdose, underdose is the big deal about this. They inhibit the breakdown of neurotransmitters such as norepinephrine and dopamine, increases the availability of components to make more neurotransmitters. So signs and symptoms of somebody with an overdose of this, nausea, palpitations, tachycardia. Sounds like it's starting to increase their tachycardia, right? The idea that they're kind of up on this. And you can think about antidepressants, what they're trying to do is elevate somebody in terms of balancing it out. So or depression all by itself is going to be that they're down. This is trying to increase that along the way. So if they overdose on it, it's going to be that much greater for them being up. And finally, bradycardia will go to that. No antidote per se, so you're going to do supportive care along the way. Lithium. Lithium is something else that's treated for anxiety. It's also treated for depression. By the way, right after my surgery, I had ongoing hiccups. I had hiccups that would go on for 30, 45 minutes at a time. And this happened several different times a day. So I called the neurosurgeon and I said, what's going on? She said, well, we're going to give you some lithium. I said, thank you very much. I'll deal with my hiccups, no problem at all. It's a nasty type drug in terms of feeling like you never ever want to get out of bed, right? Just kind of slog along very, very slowly. Nothing in terms of that. Lithium will bring you down.
How serious is the lithium overdose?
Big time. But again, from a pre-hospital standpoint, there's nothing there that's as far as the cancer that you're going to get.
I transported somebody not too long ago, a month ago, that took lithium.
Yeah. Charcoal would be a consideration for this. All right, so let's camp here. You need to know about psilocybin. You need to know about Tylenol as well. Sit a minute. So let's camp here for a second. Psilocybin. 5-7 overdose will include rapid respiration. And again, I've kind of been telling you this for 2 modules now, but rapid respiration is not in the 20-25 thing. We're talking about 30, 40, and 50 times a minute in an adult population. Then what's going to be in the pediatric population. So very, very rapid respiration. Hyperthermia, confusion of lethargy, cardiac failure. Talk about cardiac failure, what are we talking about?
Cardiac arrest.
Acute, what? Acute CHF. Arrhythmias, abdominal pain, vomiting, emesis, pulmonary edema, acute respiratory distress syndrome. That sounds like fun, doesn't it? Based strictly on too much aspirin. But aspirin does not play well within the body itself. We don't appreciate that. Just a couple of aspirin, but it doesn't play well in the body at all. Check this out. You need to know the phases in general. I will ask you about different phases in general. So have an idea in terms of what they do. I'll let you write it. Tell me the differences between the 3 different phases.
That's the progression of potassium loss.
Yep. Take time. What else?
So the body can compensate one of the replenishes.
Good. Good. Perfect. What else? So if there's loss of potassium, if they're hyperkalemic or hypokalemic, if they're hypokalemic, what are we going to do about that? How are we going to see that? How are they going to present to us? Absolutely, in a huge way. So usually pretty hard based on the hypokalemic, right? So the presentation is that they're going to be unconscious or altered conscious, depending on which phase that we find it in. So you would hope that most of our patients that we're going to see from this is going to be in this phase right here, right? But the idea, you can have somebody that's lying on the floor that's overdosed and moving by themselves, lying on the floor for a day or 2 days or something like that before you end up finding them away. Certainly unconscious, but as long as the respiratory side of this, and again, this is a respiratory alkalosis that's creating this entire thing from this right here. Okay? So as long as the lungs can do the thing, they're going to be breathing along at 40, 50 times a minute. So the acutely toxic dose of aspirin is generally considered to be greater than 46 tablets in titer. Moderate toxicity is up to 300 milligrams per kilogram, which is 93 tablets, and 300 to 500 milligrams in severity would be 154 tablets. So think about a bottle of aspirin, and that somebody's that desperate, they end up taking half a bottle along with alcohol, along with something else along the way, and that's what will get you in the end. Okay. So in terms of our treatment, again, identifying for what it is, contact and portion control for the possibility, considering charcoal, certainly putting them on a monitor like way up here, obtaining venous access along the way, and what else? We're going to intubate these patients. If they're unconscious, they got a GCS of 7, we're going to intubate them, right?
Oh, they need to keep up that respiratory. If they're maintaining that respiratory rate, they need to keep that up and keep blowing that off.
So even if they have a GCS of 6, you're not going to intubate this patient?
As long as they're keeping the blow off, if they're maintaining that, if they, once they stop, then I'm gonna, or slow down, I'm gonna intubate them.
Spot on. The idea in terms of intubating these patients just because they have a GCS of 6, they're unconscious along the way, is not good practice. Okay? There's no way that you'll be able to keep up with the respiratory rate that they're doing all by themselves. So they're still in that respiratory alkalosis. They'll remain there until the respiratory section will be the sea.
Well, they're pretty shallow.
Typically not. Typically it's going to be very deep. That's the other thing about the respiration. There's one more reason as to why you don't want to intervene. Is oxygen a good thing? Yeah. So hypoxia would be the other thing that's part of it. Right? How would you treat the cardiac side of this? You know, you would think bicarb, but they're already alkalotic, so would you get bicarb? Right? So from a metabolic standpoint, you're thinking about metabolic alkalosis, right? But there's also a respiratory alkalosis that's part of this as well. So the idea of giving bicarb, again, is not your best move. What is your best move? Getting them to Josh Mira and let him figure it out in terms of the respiratory side of things. Getting them to a toxicologist that's going to work on this. These patients end up in dialysis, number 1. Their liver is shot, number 2. They end up, in some cases, dying from that overdose 4 to 5 to 6 days after the fact in hospital. Secondary to the liver being shot. Right? So bad stuff, yeah.
Can we talk a little bit why, how the aspirin is going to go into an alcoholic state and you have that hyperventilation?
Sure.
Just a refresher, I think I might have lost that.
Right. So by the drug itself, think about that base in 0.14. And so this is an alkalotic side, okay? So as long as the drug itself is going to kick in, it's going to get worse and worse and worse over a period of time. So they're in this aerobic metabolism. They maintain that. But over a period of time, what's going to happen is the respiratory side is going to slow down and slow down and slow down. They end up in a metabolic acidosis.
Okay, and why do they go into an aerobic metabolism?
Just because that's the way that the medication drives it.
Okay, yeah, that makes sense.
We're just kind of thinking, since aspirin inhibits the aggregation of platelets, are fluids going to hurt them at all?
No. Okay. No, it's not going to make any difference, but it's not going to hurt them. And you're exactly right. It's going to have an effect on platelet side. So tomorrow you're going to get into hematological problems. You're going to hear about to where they can bleed out all over the body. I'm sorry. No, it's up to you. Obviously, it's not right now.
Is that Bengay and icy hot on there?
Yeah. Yeah. So what's that about?
Is that if you're ingesting it, or you can
Just on the
actually absorb
skin.
enough of it?
So just on the skin. Back in the days, something was called, it's up there, this oil wintergreen right here. Back in the day, this was something that you would rub on your temples, and people still have it available to them. You would rub on your temples, and it would dissolve through the skin, and would end up taking away your headache. So instead of taking an oral dose of aspirin that you do instead, Bengay essentially is the same thing. Bengay is nothing more than aspirin within that. So you rub it on the skin, and if you rub enough of it on the skin, you do it often enough, it's going to absorb through the skin and cause the same thing. Would you still have patients that might ingest it? I suppose you're creating that along the way. That possibility exists, but No, the scale bikes up with it.
I'm not following that. How much would you have to be?
I don't know.
Cause I took a watch when I was in high school.
Yeah, no. We're not talking about that. We're not talking like a muscle cramp or like that. We're talking about mass.
Massive amount.
A toxicologist would know that answer.
The MSO that we have in District 11, he talks about kids. When he was younger, there was probably working, getting into the wintergreen oil and causing big problems.
Mm-hmm.
I could see a peds maybe more than a.
Yeah, I just don't know where that cutoff is, as to how much they would have to have on board for that.
One of the smaller kids, you think
Right.
less is going to hurt.
Right. But let me ask you this: speaking of kids, what population would you see salicylate overdose primarily?
Kids.
This is youngsters. This is that 16, 17, 18-year-old that's just finding about something in life, right? And they take half a bottle of aspirin.
They don't understand the.
Nope.
ramifications of what they've done.
Nope. Yeah.
What about Pepto-Bismol? Is that?
Pepto-Bismol. Think about Pepto-Bismol. It's got a base type thing. So you take enough Pepto-Bismol, then it would create the same thing with that.
Is that like a huge dose over an extended period of time?
I'm sure of that. Yeah.
So I've got a buddy that anytime he goes out and drinks, he doesn't dose it at all. He
Yeah.
just grabs a bottle.
Yeah. And I just don't know what that limit is. All right. So let's go something more, just a wee bit different. So let's see another thing. One more type thing. We're taking Tylenol all the time. I will tell you that what I've got going on, Tylenol is my drug of choice, but in a small, moderate dose, right? We're talking again, just like aspirin, we're talking about a large dose. But even as compared to aspirin, this overdose is even worse to the liver. Does even worse number on the liver along the way. We'll talk about this in stages. So use to treat fever and pain, you know that, and large doses can be very dangerous. So the idea of about 46 tablets or so will get you into trouble as far as 325 milligrams. You need to know the stages. So stage 1 is that first half hour to 24 hours. Nausea and vomiting, weakness and fatigue. Where are you going to see most of your patient population with this? Right here. But again, given the same scenario that you've got patients that are carrying on for a couple of different days along the way before you get called for it, you can get into stage 2 or 3. Stage 2 is 24 to 48 hours with abdominal pain, decreased urine, elevated liver enzymes. So again, the liver is trying to take care of business in these patients. So just thinking outside the box a little bit, what other patient population would be in trouble given this right here?
Liver failure.
Yeah. So I heard alcoholic back here, liver failure, right? So for whatever reason they're in liver failure, the liver is already shot to begin with and can't take care of this. Stage 3 is 72 to 96 hours liver function disruption. Stage 4, gradual recovery or progressive liver failure. So again, kind of like I was talking about with aspirin overdoses. These patients, if they survive this right here, they survive the first couple of days, they may go on to surviving this, although the liver will be completely gone at that point, looking for a liver transplant, or they end up dying several different days in an ICU setting.
And obviously, there's vomiting and nausea.
Yeah.
But there's also got to be just generalized pain. I mean, who thinks this is a good idea to die this way?
They don't think they're gonna die this way.
But again, they don't know about the effects of just taking Tylenol or just taking aspirin along the way. You talk to people around you, and they will tell you that it's no big deal to take Tylenol or aspirin. Yeah.
My wife's a mental health clinician and does mainly like kids and youth. And between aspirin and Tylenol overdose was one of the biggest things she did. They'll come in, in the ER or whatever, and they think they're fine because they're not really showing any symptoms. Parents think they're fine, why can't they just go home? And she had to explain to me, probably going to be dead the next week.
Yep.
And she says 9 times out of 10 they end up being dead.
Yep.
But they just don't. They show those really small signs and symptoms, but no one really thinks.
So how many of you would get excited about the fact that somebody's got nausea and vomiting going on, weakness and fatigue? I mean, how many patients do you see on a daily basis that present that same way? Right? Yeah, you're exactly right, Jeff. The idea in terms of suspicious about history along the way. Again, and I keep, this morning I keep picking on the 16-year-old, 17-year-old, but the idea that is the population. The idea you have a 16-year-old that says, oh, I was just kidding about a suicide attempt and stuff like that. I just happened to take some Tylenol along the way. They need to be transported.
When they're trying to kill themselves with acetaminophen and something, or things like that that just destroy their liver, doesn't that remove them from the transplant list?
Great question. I don't know that I know that answer.
And Gary, if we catch them soon enough, how much they take a bottle, right?
Yeah.
And then they call 911.
Yeah.
How soon can we get those pills out of their, not we, but how soon can they get those pills out of their stomach before they start to break down?
Yeah, great question. So charcoal is still part of the answer in terms of this, as far as, and especially most of our population is going to be right here, right?
Yeah.
So the idea that either you or in hospital is going to be sticking NG tube on them and trying to lay some charcoal on them. But the idea that it's not going to completely take care of business. The sooner you can do that, the better off you're going to be in terms of these stages right here.
Will they try to actually make them maybe gastric lavage or something to throw those pills up?
Yeah.
Or?
Well, no, they're not going to make them throw it up. But the idea in terms of NG tube is going to start breaking down within the first couple of hours. So that's what they're after with this.
What's wrong with throwing these things up? A lot of the substances do not induce emesis.
Yeah. So yeah, that's all it is, Trevor. The idea in terms of aspiration. That's why an NG OG tube is going to be a better move for trying to do that. The pill form is still going to be there, and so they're going to continue to do lavage, what they call a gastric lavage. They wash out the belly and everything else like that, and that's what they're going to be after. The cathartics that I talked about earlier on this morning, the idea in terms of the excretion side of this, will be something else they will lay on these patients as well.
But throwing it up would be your best bet.
If you can prevent aspiration, yeah.
Okay.
So for acetaminophen, there is an antidote. You need to know this. Acetaminophen or mucomist. Mucomist is the common way you hear about this. It's highly effective, rarely given in the pre-hospital setting. So we're not carrying it. And I don't know of anybody that is carrying mucomist. But it works very, very well in terms of acetaminophen overdoses.
They have it also.
Yeah, in hospital they do. Yeah.
Oh, okay.
Yeah. All right. So NSAIDs, ibuprofen. Some interesting things in terms of signs and symptoms of toxicity. Headache, ringing in the ears, nausea and vomiting, abdominal pain is huge. GI bleeds is huge in terms of NSAIDs. So Advil, Motrin, very, very common. And again, the general population does not know about taking a larger dose that's going to create this abdominal pain and GI bleed. Swelling of extremities, mild drowsiness, dyspnea, wheezing, pulmonary edema, rash or itching. The most common thing that I've seen in terms of overdoses is this right here. This is abdominal pain, nausea and vomiting, and GI bleeds. I talked about iron a little bit earlier, especially with kiddos. Body requires only a small amount on a daily basis, maintaining the store of enzyme and hemoglobin production. So you have a gal who's pregnant that's on prenatals, and the prenatals is essentially iron. The whole thing about that is to work on anemia states. So anybody that's anemic along the way, they're most always going to be on iron. They're under somebody's care. But to that, when we have an overdose with that, it's very, very nasty in terms of possibilities. Excess cause GI injury. So as you might expect with this, vomiting and diarrhea would be very, very common because the body's trying to excrete it. You can have somebody with abdominal pain. And this was the one I was talking about with pediatrics, that it can get worse over a period of time. So just because they're standing there smiling at you when you walk in the door, does not necessarily mean it's going to turn out that well. This chelating agent that I was talking about, where they cause them to move it out through the stool, is one of the classic things they use for iron. Because activated charcoal will not bind to the iron, charcoal is not given here. But this chelating agent is. And so you hear about heavy metals, as in not a music type thing, but heavy metals in terms of things in the ground, the likes of. That's what we're talking about here for any, not only iron, but any of the stuff that's out there like it. All right, almost there. When we talk about substance and overdoses and addiction and the likes of, I'm acquired. I know that your patient population is that. I know that you're working with that. We talked about way earlier on about having the right kind of health to take care of these patients. And they're not an easy population to deal with, but nevertheless still a one that you have to deal with. You should know these. You should know these definitions. They should be part of your vocabulary as far as to spit them out. I'm not going to hang out here. Same thing here. Tolerance and withdrawal. I'm not going to hang out here, except to say with continued use, the user can use increasingly larger doses. Heroin is a classic example. That's going to be more and more maintain the same kind of high. I think that's the same. Not the same way.
We had a guy yesterday, just got out of prison, using them for, I think it's like 2 months.
Yep.
Got out, had a big party, phone for him, smoked meth again for the first time, so not that he used to.
Yep.
He was.
Yep. So, to no one's surprise, least of all, your alcohol, amphetamines, and barbiturates are the drugs of choice. So check this out. I want you to know this. The idea that anytime we talk about alcohol, we're talking about downer type signs and symptoms. Okay. The idea in terms of that is going to be maintained much the same. ABCs, respiratory support because of the depression side of this. Oxygenate if hypoxic, establish an IV, administer 100 milligrams of thiamine. Okay, and that's new to your vocabulary, but 100 milligrams of thiamine is part of the care, not just for the weekend alcohol. Weekend person that has been binge. It's somebody that's a chronic alcoholic. Thiamine is a B12 that's going to be part of Wernicke's versus protocols. I'll talk about that in just a second.
I knew some of the older, more experienced medics loved thiamine, missed it. Why is it going
I don't
on?
know. I don't know the answer as to why it's not being given here. My thought process probably is we just don't see enough chronic alcoholics. Chronic alcoholics in the stage of Wernicke.
Okay, all right.
As you might see in a larger city. In my opinion, should it still be given here? I think it should be considered. But again, take a look.
Yeah.
It is. Yep. Yeah. Are you guys getting in? So one of the things, okay, again, let me stop my foot because of past students, past classes refusing to get this. Why is this a big deal right here? Somebody that's going through withdrawal. What's happening in terms of how the body processes glucose?
Brain burns do a lot of sugar.
Yep. And then what?
Then he crashed.
And then as they start to either go into their withdrawal. So hypoglycemia is your patient. And oh, by the way, when they act crazy based on being hypoglycemic, would you expect somebody in withdrawal to be crazy? Yeah, so the idea of 1 + 1 does not equal 2, equals 3. If you're not thinking about hypoglycemia. What's one of the things that would be good to get in these patients? It's up there, but one thing I want to start my foot on. It's about this right here. 12 week. Why 12 week? It's just a fall down drunk, he's going through withdrawal. This is my 4th time, 4th patient today of the lights out. Why is it a big deal? These patients are set up in terms of cardiac artery. In a huge way. So the consideration toward getting 12 weeks, at least 3 years before we go. So barbiturates, we're talking about phenobarbital, and I know we talked about that a couple of weeks ago. Phenobarbital is also a drug of choice for seizures. But in this case, they can overdose on it for whatever reason. Okay, look at how it presents. Again, a downer type thing. So again, your setup is going to be kind of the same thing. It's going to be supportive. Cocaine and meth will be the same thing in terms of they can be up for hours and days at a time. So this euphoric type thing. Are these patients going to be typically you're getting in the fight with you? That's a possibility, yeah. So the idea, are we going to solve anything in this population? What are we doing for this population? Yep, and if you can get it, again, based on the fact that I might be fighting with you. But what else?
Restraints.
Possibility of restraints, absolutely. Physical restraint might be a possibility. There's something else up there.
Oxygen, IV, seizure precautions.
How about some chemical sedation? Right? And what's your drugs of choice?
Diazepam or ketamine.
So ketamine all by itself is that possibility, okay? But I'd be thinking more about the benzos than I would about ketamine per se. Okay? I'd be thinking about lorazepam or Ativan. I'd be thinking about Versed, and I'd be thinking about diazepam or Valium. The Brady book loves diazepam, and so in your book you always see diazepam. But I'm here to tell you that what you will carry your toolbox around from these parts is going to be lorazepam, Ativan, or Versed, midazolam. Right? Those are the two drugs of choice. Doesn't mean that you can't use the other.
In some ways, this patient's going to mimic excited delirium.
Absolutely. That's exactly the point. The idea that the fight is on, the idea that they can have dry skin. Same thing with meth. I mean, very, very same thing.
So with excited delirium, where ketamine is a great go-to.
Yeah.
Why not?
So it isn't that I wouldn't go to ketamine, but probably, and we'll talk about this next week, but probably what I'm going to do is I'm going to start with a benzo, and then join ketamine with that. Jeff, I saw you first.
This might be for a later time. Going through our ketamine drug profile and what they were talking about with the city getting, there's a lot more cardiac issues that's related to.
Yeah. So time out. Just set aside for just a second because there's something I want to tell you about. So you may have seen it already. You may have heard about it, but obviously ketamine is going to be starting to carry here in Spokane County. And Dr. E had done a Vimeo webinar next door last month, I think it was, a month or month before. And I just, while you were doing your module test last week, I got a chance to sit down and actually take a look at that. Man, I'll tell you what, that is packed, hour and a half long. It's packed with a lot of stuff that he's talking about. And an interesting thing of what he's talking about is there's some downsides to using ketamine and this type of thing. And so because it's so full, and initially what I wanted you to do was just go back and take a Vimeo outside of class and they'll talk about it here. But because it's so full and so packed, I'm going to see if I can't get him in here sometime along the way to talk about the same presentation. And so you'll hear about some other effects about ketamine that probably we haven't been talking about. Okay? So we'll see. So back into play with that. Where you're going initially is you're going to be going with your benzos. You would consider, I probably would not give ketamine just out of the box, but I probably would be calling somebody else along the way to give ketamine alongside that. Makes sense? Sure. Anybody else? Yeah.
So I'm sure their metabolism is going to be best. We want to check the sugar and glucose.
Oh, absolutely. Absolutely. That should go along with any population.
Would you expect the percent to let that wear off faster?
Yes. In all cases, metabolism is going to be up. But the one thing you want to be careful of is on these patients with meth, on these patients with excited delirium, they do this, and then this. And that's exactly what we'll talk about next week as far as the way they crash out. So you want to be much more, don't be cavalier just because you have it, but the possibility of just trying to take off the type of things. That's what you're after. So narcotics, the drug of choice these days is heroin. Greg Vandenberg from Spokane Police Department will be in next week. He's going to be talking to you about street drugs. And he'll talk to you a whole lot more than I have the possible time or effort to do. And he'll be talking about the fact that, well, heroin is the drug of choice here. Fentanyl is the other one that is side to that. Okay. At the very tail end of this, we're going to talk about one other combination to that as well. And just in case nobody told you, marijuana is legal here in Washington State. However, as Greg will talk about next week, the idea that polypharmacy, marijuana, and something else along the way should be in your hip pocket for the possibility.
What was the term for that?
CrossFit.
Cross what?
CrossFit.
What is it?
CrossFit. Cross.
Okay.
You never heard of that?
No.
Why are we speaking this quiet voice with them? Is that just so they don't look at us and be like, hey, chill out?
Yeah. So, what's Ritalin? Ritalin is essentially speed. When's it used? ADHD, right? So I would tell you that I have 3 sons, and all 3 sons had ADHD. Lucky me, right? But to that, the idea that they were on Ritalin in the pediatric population, it will slow them down. In the adult population, it will do what? Speed them up. So the idea that if somebody was looking for a high, guess what they would end up stealing from a pharmacy or from somebody else? Ritalin. It's a controlled drug. Okay.
Adderall.
Adderall is another one, yeah. So again, methods within this room right here. Excited delirium is certainly a possibility of all that. And again, I'm not gonna hang out with each one of these. The idea in terms of you got sedatives, benzos is one that you should know about. Simply in the idea that you have patients out there with anxiety on Valium. You can have patients on lorazepam or Ativan as well. And so the idea in terms of benzos will slow you down. Sometimes it'll take away your respiratory drive if you take enough. Romanticon, we've talked about it this morning. You don't necessarily need to know that. Cocaine, we talked a couple minutes ago about the fact of giving a benzo just to slow them down a little bit. You're not going to cure them, but the idea in terms of just slowing them down, especially if there's a fight that's going on. All right, this we need to stop and camp on and just kind of talk about. So alcohol, because of the prevalence, because of the possibility of what you want to use it, if you walk into, let's kind of talk. When we talk about alcohol, we're talking about ethyl alcohol or ethanol. Depresses CNS, potentially to the point of stupor, pulmonary death. Not that any of you experience that along the way, but nevertheless, causes peripheral vasodilatation. Why is it a big deal? Vasodilatation. Yep, hypertension would be one. What else? Say again?
Be easier.
Yeah, we talked about it earlier on this morning. What else?
Peeing a lot.
Yep, so that they're peeing out, so they're dehydrated. Okay. What else? Yeah, so it's kind of well, just going out and drinking too much overnight is not necessarily going to do this, but chronic alcoholics will do that in terms of subdural bleeds. Okay. What else though about the vasodilatation?
Deadened senses, so if they do get hurt, they don't realize it.
Instead of nice, balmy, 50-degree weather out there, we have weather that's only about 6 degrees. And you have somebody that walks out after binge drinking and lays in snow. They're vasodilated already, so what's going to happen in terms of temperature? So the idea in terms of vasodilatation has a much greater effect in the environment. So you should know this already, but general profile would include impaired control of drinking, preoccupation with alcohol, use of alcohol despite the possibilities, distortions in thinking such as denial, drinks probably a day, prone to drink alone and secretly. The idea in terms of binges along the way. You can have somebody that is rock solid stable 75% of the day, or 75% of the time. And they end up going on a binge for 3 or 4 days at a time. That's considered to be alcoholism all by itself. Yep. it will have the same effect in terms of the overall condition of the patient. Sorry, Craig, you have to clean this up.
I know, Craig, right there.
And that's kind of this right here. The idea in terms of blackouts go along with alcoholism. Not an old age where I can't remember where my key's at, but blackouts in the sense that you totally space on periods of time. Totally spaced on hours and days at a time. That's what we're talking about in terms of blackouts. Why GI bleeds? And that's primarily what we're talking about is GI bleeds. What does it do? Yep, how so? You're right, but how so?
Oh, they vomit a lot.
Yep, that's one. What else?
It's sort of that lining, and then your stomach acid eats away.
So what does the pancreas do in terms of not in maintaining the glucose, but what does it do on the digestive side? Pancreas, huh?
Production of bile.
Yeah. So the idea in terms of alcoholics, because of all the vomiting they do along the way, pancreatitis is very, very, very common. When you hear about pancreatitis, not all cases, but when you hear about pancreatitis goes along with alcoholism. So that's one organ that it affects. What's another organ that it affects? Liver in a huge way, right? So cirrhosis of the liver goes along with this. So as a result of that, when we talk about GI problems, we're talking about varices somewhere along the way, somewhere along the GI tract. It could be the esophagus, it could be lower down in terms of the stomach itself. So pancreatitis that goes along with it. This green tongue syndrome, I don't know that I've seen that, trying to disguise smell, alcohol, and breath, but the idea that you have, for lack of time, the idea that you have somebody that's trying to hide that they had a drink would be this right here. Cigarette burns on clothing because they're falling asleep. Chronically flush in face and palms. They have tremors. Usually, as long as they're drinking along the way, the tremors are not that big, but they go through withdrawal hours to days, and the tremors will start. So you should know this in the sense that of all the things happening within the body, as far as the chronic alcoholic. And again, I'm not going to hang out here. I'm going to let you go back and take a look at this in your own time. But the profile, if you will, is they come across in many, many different ways. We talked about cirrhosis. Talked about alcohol hepatitis because why? Yeah, liver is affected by this, right? Liver is shot. Usually poor eating habits, loss of sensation in the hands and feet because of neuropathy there. Loss of cerebral function, that is balance and function, and not just when they've been drinking, but just in general. And again, this is set up for not only bleeds from their falls, but also bleeds in general, just because of poor circulation into the brain. Talked about pancreatitis already. Upper GI bleeds go along with this. Hypoglycemia is the reason why. And every time I'm going to ask you this question from here on out, I want you to tell me about checking for sugar every single time. I'm going to ask you plenty of times from here on out. Subdural hematomas is another consequence to it. Rib and extremity fractures, again, secondary to falls. Talked about subdural hematomas. Sepsis is a part of it because of poor lifestyle, where they're living life. DKAs can show up this way. So again, this population, their glucose is going to be all over the place. It's pancreas on the excretion side is part of this. Pancreas on the glucose side is part of this as well. So not only can they be hypoglycemic, but hyperglycemic as well. Glucose to 450, 500 with type 2 diabetes that we'll talk about next week. So when they go through withdrawal, reactions from abrupt discontinuation of ingestion after prolonged use can be potentially fatal. Usually, not always, but usually withdrawal will happen within hours and can last up to several different days. So those of you that are going into places to where patients are coming to withdrawal, the idea I want you to start thinking a little bit differently as far as what's going on when you're using treatment along the way. Fair enough? So here we go. Wernicke's corsicles. Wernicke's condition is characterized by loss of memory, disorientation associated with chronic alcoholics, intake and a diet deficient in thiamine. Versus Korsakoff's, which is psychosis characterized by disorientation, muttering, delirium, insomnia, delusions, and hallucinations, may be irreversible. So, what's our drug of choice that we're giving to alcoholics? Not we here in Spokane, but what are we giving? Thiamine, 100 milligrams, right? The idea that we're giving thiamine to try to take care of this right here, versus this, that is more of a dementia type setting, okay? So the idea that this will turn into this over a period of time. Now, can you guys recognize that in the field setting? No. But you need to know that in terms of the sense that over a period of time, that if they don't change their lifestyle, they don't get themselves cleaned up, if they're not intervening somewhere along the way, this is the end point for these patients. Make sense?
Are they getting binding to Korsakoff's patients as well? Or?
Just because in the pre-hospital setting, just because they don't know what stage they're in, if they find down with alcohol on board, they're going to get thiamine in all cases. In the pre-hospital setting, you may not know the difference between the two of these. So the answer is yes. So same with the withdrawal. Seizures may occur within the first 24 to 36 hours. So our benzos are going to be our drugs of choice. We're going to expand in terms of our doses from here on out. So as we start talking about this, while we've talked about 1 to 2.5 milligrams of Versed, we're going to expand that 1 to 5 milligrams, and sometimes 1 to 10 milligrams of Versed. We haven't talked about Ativan or Razepam yet, but we'll do that next week. So the normal dose of Ativan, as you find out next week, is going to be somewhere between 1 and 4 milligrams. So you can do that for seizures in this case. Diazepam somewhere between 5 and 10 milligrams. So other signs and symptoms, you need to know this. I'm not going to hang out here, but you need to go know this and go back and look at your slide. The idea that in many cases it's going to be the shaking type thing. And the idea that the balance is going to be off. The idea that they're going to be nausea and vomiting along the way. You've done it, you've seen that, you've done it, you touched it. But the idea in terms of how they respond to you and how they present themselves. Other signs and symptoms would include hypertension. Oh, by the way, hypoglycemia, in case I haven't talked about it enough, will be part of this thing as well. What are you going to do for it? The idea in terms of maintaining an airway, the idea in terms of starting an IV, are they going to be dehydrated or not? In a huge way, right? So for all the diarrhea and all the nausea and vomiting and all the peeing is going to make them dehydrated. So much fluid on the patient. With the idea, they probably have comorbidities. That is, they probably have a history of COPD. They probably got a history of asthma. They probably got a history of something else along the way. So don't run fluid just wide open without doing something along the way in terms of checking. Cardiac monitor, 12 lead, checking the sugar, supportive care. All right, carfentanil is the last thing that I have for you. Have you guys heard about this? Yes, so it's here. Greg will talk about it next week, but I just wanted to highlight it for just a second. First developed in the 1970s, it's considered a Schedule II narcotic. It's 100 times stronger than fentanyl. So remember that morphine is a standard, right? And fentanyl is like 10 times stronger, 100 times stronger than morphine. This is 100 times stronger than that. So it's crazy in terms of possibilities. It's an anesthetic for an elephant. You know that. Generally imported from China, where it's considered to be illegal. So there's several different YouTubers out there that kind of talks about this. And in China, it's no big deal. They will sell it to whoever will want to buy it along the way. It doesn't matter. That's a big deal here. They will continue to produce it and sell it along the way. Heroin or fentanyl is laced with carfentanil, which is part of the craziness that you're seeing on the street for the way they end up at. 2002, Russian special forces put carfentanil through air vents through Chechen separates. We're holding 800 hostages. There's only 100.
Did they get the separatist stuff?
Any chance we'll get it as an all-nighter?
Not in this lifetime.
Long-term,
Yeah.